Hi Cindy, my name's Christine. I'm an AUT student paramedic. Your family have called us here today because you were very hard to wake and unconscious, and also a wee bit confused on waking this morning. Is that normal for you? Would you normally be hard to wake?
No.
No, okay. Hey, do you have diabetes or any diabetes in the family?
We have diabetes in the family.
But you don't have diabetes.
No.
And did you have any chest pain or shortness of breath?
No.
No, neither of those. Okay. Hey, have you noticed any changes in your weight recently? Weight gain or weight loss?
No.
No. When did you last have something to eat? Yesterday. What did you have?
A sandwich.
A sandwich. So was that around lunchtime?
Around lunchtime.
Okay. And do you have much water to drink throughout the day? Have you had any water today?
No water today.
No water today. When did you last have something to drink?
Yesterday.
What was it?
Water.
It was water? Okay.
And wine.
And wine.
And wine.
Okay.
And some beer.
And some beer. All right. Okay, so you drink quite a bit?
Yes.
You do?
Yeah.
Okay. Would you normally have wine for breakfast?
Yes.
Some days?
Some days.
All right. Well, I notice you're all rugged up at the moment. It's quite warm in here. Do you normally have trouble regulating your body temperature?
No.
You don't normally feel cold or hot excessively? Okay. Have you noticed any changes in your skin? Like, is it rougher, smoother, drier?
No.
No changes? And has there been any vomiting or nausea or diarrhea recently?
No.
And what about in the family?
No.
Nothing within the household? Coughs, colds, flu-like symptoms?
No.
No, nothing? Okay. How's your sleeping? Do you sleep very well?
Yeah.
And how many hours would you say you sleep through the night? Is it uninterrupted? Straight through?
8 hours.
Okay. How's your hair? Have you noticed any changes, thicker, thinner, falling out?
Oh, falling out. A little bit of falling out.
A little bit of falling out. Okay. So I noticed you've got a bit of a shake there going on. Are tremors normal for you?
No.
No? When did they start?
This morning.
This morning. Is that just after you woke up?
Yeah.
Okay. How are your eyes? How do they feel? Do they feel gritty or dry or
Blurry.
a little bit blurry?
Yeah.
All right. And what about your voice? Have you noticed any changes in your voice?
It's a little bit deeper.
A little bit deeper. I hear you're a bit husky as well.
Yeah.
When's that started?
This morning.
Just this morning as well. Okay. Well, Cindy, if you wouldn't mind, I'd like to have a listen to your chest. So just the front and the back. For the purpose of the video that you're being recorded in, I'm not going to ask you to lift your shirt so I can have a go. I'm just going to go over the shirt. But I'd also like to have a feel of your stomach, okay? Is that alright? So if you have a lie down, I'll have a feel of your stomach, and then we'll have a listen to your chest. Alright, so just let me know if you feel any pain or discomfort as I'm having a feel here. Okay, very good. If you can have a seat, I'm going to just have a listen to your chest. And I'll get you just to breathe normally for me. Nice big breaths in and out. The physical exam techniques used in a focus endocrine assessment are the same techniques used in general exam: inspection, auscultation, palpation and percussion. During inspection, you're looking for conditions which can be observed with the eyes, ears or nose. For example, generalised appearance, skin colour, location of lesions,
bruises or rashes, symmetry, size of body parts, or abnormal sounds or odours. Auscultation is used in the focused endocrine assessment before percussion or palpation. You're listening for murmurs, cardiac irregularities, adventitious breath sounds or alterations in bowel sounds. Palpation allows you to assess for texture, tenderness, temperature, moisture, internal organs, pulsations or masses. And abnormalities that you may percuss are enlarged pancreas, pleural effusion associated with specific endocrine abnormalities, or a hormone secreting tumour.
So if I can get you just to stand there, get your balance, and then I'll ask you to close your eyes. Just hold that pose. Very good. Okay, you can open your eyes again. Now, if I could ask you to walk forward, I'm going to get you to put heel to toe, and then walk backwards. Alright, then forward again on tiptoe, and backwards. And then forward on your heels, and then backwards. Alright, so if I could get you to stand up straight, raise your arms, palms out straight like you're holding a tray, and then when you're ready, close your eyes. Hold that position. Okay, with your eyes remaining closed, I'm going to keep your hands there, going to lightly touch one of your fingers, and with that finger I'd then like you touched your nose with it. Alright, very good. You can open your eyes again. And if I can get you to play the piano, tap your wrist really quickly, under and over. Alright, then looking at me, give me a nice big toothy grin. Raise your eyebrows, blow your cheeks out. Okay, now I'm going to shine the light in your eyes. If you could just continue looking at me. Oh, very good. I'll ask you to stick your tongue out, wiggle it in and out. Okay, and now if you could just look directly at me, and then I'm going to move my fingers. I'd like you to point at the ones which are moving. Very good. Without moving your head, continuing to straight at me, I'd like you to follow my fingers using only your eyes. Only your eyes. Wonderful. So I'll get you to raise your shoulders, lower them, and I'm going to apply resistance. Raise your shoulders, lower them. Fantastic. Have a seat. You could put your feet up for me. This is going to feel a bit weird, but I'm going to touch the bottom of your feet just to relax. Okay. And if you could recite Mary Had a Little Lamb for me.
Mary had a little lamb, his fleece was white as snow.
The fast test can be used in a patient who is suspected may have had a stroke. A more in-depth test can be used in patients who are suspected of having concussion or diving-related injuries such as the bends. The Romberg test is important for proprioception. Most patients and most people should be able to stand with their eyes closed and not wobble. Some people who are anxious will wobble and flail their arms. If anxiety has caused the wobble, they will be able to walk tandem gait. The heel-to-toe walking can be done forward and backward in normal adults. Testing of plantar flexion and dorsiflexion, most people should be able to walk on tiptoes and on their heels. Primordial tracts are tested when the patient stands with their arms outstretched, palms facing upward and fingers outstretched. Normal adults should be able to hold this position without pronated drift. Cerebellar function is tested by light touch with the finger to nose test. Difficulty can be increased by asking the patient to touch their nose to the practitioner's finger when the practitioner will move their hand at the last moment. With their eyes open and playing the piano, we're testing primordial function, and then the rapid sequence of movement tests coordination and ataxia. Testing of the face can be done by asking the patient to screw their eyes shut. We're testing cranial nerve 7. Then asking the patient to show you a big toothy grin and raise their eyebrows, blow out their cheeks. Normal should be symmetrical. When the patient opens their eyes, we're looking that the eyes are pearl pupils equal and reactive to light, cranial nerves 2 and 3. Cranial nerve 12 is tested by sticking out the tongue, and then the rapid tongue movements test for cranial nerves 9, 10 and 12. Checking the visual fields, we're looking at cranial nerve 2, eye movements 3, 4 and 6, and then the shoulder, we're looking for symmetry in the rays, cranial nerve 11. The Babinski response is tested on the sole of the foot when it is stimulated using a blunt instrument. In normal adults, the plantar reflex causes flexion, a downward response. Speech is also tested by listening to the patient's spontaneous speech, noting the volume, rhythm and clarity. If any of these tests reveal a response other than normal, it could indicate damage to the central nervous system. My key takeout message is that confusion has long been considered a normal consequence of ageing. The history is the most important aspect of the examination of the confused patient. Onset of symptoms, corresponding illness, medication use, and time of day that the confusion occurs should be included. Confusion is a symptom of many different and often unrelated disease entities. Many of these diseases are preventable, curable, or arrestable. Some differentials could be trauma, postal state following seizure, TIA or stroke, hypoglycemia, infection, or drug and alcohol use. Poor physical examination skills are a threat to patient safety as the probability of diagnostic errors and oversights is increased. Moreover, unnecessary investigations themselves are potentially harmful. If you're considering a cerebral event at the conclusion of your patient assessment, it is important to consider timing. Do not get caught up performing extensive examination that may cause transport delay.